plans for high payments, or alternatively that the providers with market power get what they want, and it's the have-nots who suffer. So people on our committee suggested that if you're going to go there, you have to actually go to looking at those contracts. Um, and limits on out-of-network billing. This is based on findings that in Medicare, because Medicare has a rule that says that Medicare Advantage plans can't balance bill beyond the Medicare rates. That completely changes the negotiating dynamics, and in fact, Medicare Advantage plans pay at about Medicare rates. So some notion of putting a limit on balanced billing as a way to discipline the negotiations, setting upper limits on permissible negotiated rates, or alternatively focusing regulatory limits on health systems that exceed a certain threshold of consolidation. And at the far end is expanding the use of all payer or private payer rate setting, actual direct regulatory limits a la Maryland, which does all payer, or West Virginia, which does private payer. I've got 2 or 3 more slides, and then we'll move to discussion. We did not include payment reform as one of the options. And in fact, our greater concern was that some payment reforms would increase pricing power and pricing differentials rather than solving the problem. I co-authored a piece called Unchecked Provider Cloud in California Foreshadows Challenges to Health Reform in 2010, with the idea that some forms of consolidation might actually raise prices, even though they're now in a position to accept global payments. Michael Porter at the Harvard Business School actually in a recent paper suggested that's a reason to favor bundled episodes to focus factories, because he thinks they are less likely to use their market power on prices than a large integrated system with receiving population. We need some data on that. The point I would make is that high prices eat low service use for lunch. So that even so, if you're taking global payments and you are doing a fabulous job of reducing unnecessary utilization, and I'm pointing to the data that suggests there's plenty of unnecessary utilization, you might save 20%, reduce, I mean, if you're really good, you're reducing utilization by 20%, but if you're getting 100% or 200% more than Medicare, that's the kind of differential. Those high prices will way outweigh what you're doing on the low spending side. And then to finish, how payment design can affect prices in commercial products. Essentially, whether or not providers' historic costs should be the basis for target spending. And it's done under various payment models, whether shared savings for ACOs and setting global hospital budgets like in Maryland and pricing a bundled episode. Do you use historic spending, or do you use some kind of community average or normative standard? Using historic costs essentially bakes in the historic pricing differentials. And so you're sort of accepting those long-term price differentials, but some approaches to updates can narrow the differences over time, and I think that's where there actually has been some efforts outside of Massachusetts. So Medicare ACOs, for example, get an absolute dollar update, not a percentage update. The trend is determined as a percentage, but it's converted into a dollar amount, so if your base is higher, you get a lower percentage update. Don, you may have had something to do with that. It was very wise, and it is the right way to do it. More generally, you can blend and transition benchmarks from historic towards the average. And there's a number of examples in Medicare and elsewhere where this notion of blending has been adopted. And you can vary the shared savings percentage in relation to the level of historic baseline spending, or you can determine notion of blending has been adopted. And you can vary the shared savings percentage in relation to the level of historic baseline spending, or you can determine any particular provider system's update. You can adjust it for what the historic spending is. And I'm finishing, which I won't go through now, but for your information, this Massey report also started looking at what states can do. And we have examples in here. There are a few from Massachusetts, but you've gone well beyond these. This was from a previous presentation. I wanted to just go to this one here. The Rhode Island office of the insurance commissioner has been granted broad authority to hold health insurers accountable for fair treatment of providers and to direct insurers to promote improved accessibility, quality, and affordability, which operationally gives them the ability to review and approve payer-provider contracts. Interestingly, they also have the authority, which they did, to tell all the insurers in Rhode Island. Now, there are not a whole bunch of insurers in Rhode Island, but the three, that they had to increase the payout for primary care physicians by 1 percentage point a year over 5 years to go from 6% of the total spend to 11% of the total spend. And they had to figure out how to do it. And that's now been accomplished. And I'm hoping to actually do a case study to see what the impact of that is. But that is the kind of authority that insurance department actually has over payers, but in particular, in today's context, the ability to look at those prices. So thank you very much.
Bob, that was a tour de force. And you have sitting behind you the chairman, who I'm sure has this all memorized, because much of this is exactly what we're talking about in our price commission. So with that, I'm going to turn it over to my fellow commissioners.
Wow. Bob, in the spectrum from fee-for-service to global payment, these intermediate forms like bundle payment, and then even putting price controls in, Elliot Fisher has worried out loud that if we don't go all the way to global payment, there will be adjustment on the volume side as we try to control price. So that you understand the problem. What do we know about that? What do you think?
I'm with Elliot. In fact, I don't know if people, this is probably inside baseball Washington style, but there's something called the Learning Action Network that CMS is contracted with to develop a framework for payment reform. And they sort of correctly critique DRGs because it still has a volume incentive. But then they move on to a bundled episode and ignore the fact that it has a volume incentive. And I have actually argued that, in fact, it could increase the volume incentive because now you've made a business entity of the doctors and the hospitals getting together. We don't know very much because CMS hasn't been looking. What they in the JAMA article they just published, they found that the hospitals doing the lower extremity joint replacements, hips and knees, had a lower per case spending. Elliott wrote a commentary pointing out, however, that those hospitals in the intervention group had more volume. What they never looked at was what happened to volume in the community or to residents of that area. One could make two equally plausible arguments. One is that there's a redistribution going on to those hospitals because they're doing a great job and because the surgeons now have a financial stake in moving the patients to that hospital, or that they're reducing demand because hip and knee replacements are one of many services for which there's a lot of inappropriate services being produced, and we have no idea what is happening. So I think we need to know. I think we need to find out. But that has been one of the reasons that I have been somewhat skeptical, because it's still a volume-based payment model, and why I personally favor moving towards sort of a global capitation approach. But in all candor, we haven't been terribly successful with that one at the national level either. So at least within the Medicare fee-for-service payments. David?
Bob, you mentioned that you're sort of preaching to the choir, and I would just like to note that sometimes the choir needs to be a sermon too, so thank you. You mentioned a couple of times in passing encouraging transparency on quality and price, and the governor mentioned it this morning as well. And I guess the question that I'm wondering is, what does the evidence suggest about what the state of the art of that is? Because I know a number of experiments that haven't managed to move where patients go across more and less expensive providers. And I know the reference pricing literature where you can do that if you're very, very intensive about it. But what do you think the agenda for that would look like?
Well, first, I make the distinction I made in my presentation. There's transparency for purposes of shining a spotlight on an issue. And that, I think, is pretty positive. You sort of uncover the kinds of data that the commission has been reporting on, and the AG's office has been reporting on. That has positive impact on moving the policy. But in terms of consumers using that information to make selection, my reading of the literature is it's not all very powerful. For 25 years now, New York State and Pennsylvania have been publishing 30-day mortality rates for cabbage surgery. And I still remember Alan Enthoven writing in Health Affairs criticizing Bill Clinton because he didn't go look at the scorecard before he decided where to have his heart surgery done. He did this horrible thing by trusting his physician to give him advice. Most people haven't been using that information, I guess is what I'd say, and there's a lot of efforts to try to make it the price side of this more digestible, because right now getting a unit price doesn't help you very much. You need to have a total price for what the hospitalization would be. Quality, in some areas we actually have pretty reliable data, like in cabbage mortality, and the differential between the bulk of the hospitals that have a 2% mortality rate and then the outliers that have a 3% mortality rate. I'm not sure that I'd be relying on that data. So I'm somewhat skeptical of that purpose, but I'm happy that people are trying. I'm somewhat skeptical of the whole consumer should have skin in the game notion that that's how we're going to deal with healthcare. And I will make one final comment about reference pricing. The Pacific Business Group on Health, or CalPERS, or those groups out there have shown that you can have some impact, but I'm actually talking now to a group in New York that's in the business of evaluating MRI performance quality. If there's a prototype of a reference pricing commodity, it would be an MRI. It's been pointed out that the prices vary by 10 times in different places. They are finding tremendous variations in quality, basically errors of interpretation of MRIs. So my view is if you're going to go this route, then you can't just assume that these are commodity services. You actually have to not only try to find providers willing to do it for the reference price, but you also have to assure a certain basic level of quality that occurs, because I don't think, as opposed to prescription drugs, I don't think most medical services are commodities, and I think that part of the equation has been completely lost in these models.
Well, Bob, I want to thank you. As I said, this was a tour de force. The information you've provided us, we will be digesting for many moons to come. So thank you so much, and I hope we have the opportunity to at least call you up and get a little more insights into some of them as it moves forward.
Always love visiting Massachusetts.
All right, Mike. All right, so you've been sitting very patiently. So I'd like to take a 5-minute break, which means 7 minutes. So, but no more, because we have a very packed agenda to go forward. Thank you so much. Is the extent to which the Commonwealth is meeting the goals of Chapter 224, and to the extent that we're not, why not? As Dr. Everett pointed out, to the extent that we've seen a reduction in alternative payment methods, why is that happening? And are there things that we could do about it? Should we be concerned about that? Third, of course, is the pharmaceutical prices and medical device prices. And then finally, but not at all at the low end of the system, is the issue of out-of-network billing, particularly as Dr. Berenson pointed out, surprise billing. So the way we're going to operate is I'm going to ask each of the panelists to very briefly introduce themselves, and then we will engage in comments and questions. So let me start off. Why don't we just go left to right? Steve, why don't you just introduce yourself? You represent.
Good morning. Thanks so much for being here for the terrific staff work in preparation for the meeting. I'm Steve Strongwater, President. I'm the President and CEO of Atrius Health, which is a globally committed primary care with integrated specialty practice committed to global care team.
Good morning, I'm Mark Kerouac, President and CEO of Baystate Health. Happy to be with you today to talk about the work that Baystate is doing to pursue high quality care and affordable costs in Western Mass. Over 70% of our PHO patients are covered by alternative methods, and this led us to adopt a number of interesting and innovative practices to reduce total expense. We're also the largest provider of Medicaid services in Western Mass, and the largest provider of comprehensive services in Springfield, which is one of the poorest cities in the Commonwealth. In our market, the days of planning for higher payment rates from commercial insurers as a mechanism to fund the entire enterprise are over. We've made a strategic decision to grow our lives in risk contracts, move to well-managed benchmarks, reduce out-of-area leakage, and remove excess capacity is the only way for us to fulfill our mission of a financially sustainable way.
Good morning, Andrew Dreyfus, President and CEO of Blue Cross Blue Shield of Massachusetts. Good to be back here. 3 quick points I'd like to make. First, our work is not done. Despite the many efforts of the people in this room, the recent CHEER report shows that the Commonwealth is above the benchmark, and we can and must do better because the burden of healthcare costs and the rise of costs continues to be a problem for employers, family, and government who are paying for healthcare. Second, we continue at Blue Cross to believe that the most effective and sustainable approach to improving quality and lowering costs is to change the way we pay for care. Massachusetts leads the nation in value-based payments for health, from health plans to hospitals and physicians. And it's encouraging that this form of payment is now gaining traction with government payers, especially our state's important Medicaid program. Third, I believe we must begin to apply the same focus on value to another key issue, the rising cost of prescription drugs, especially the high cost of specialty medications to treat rare, acute, and chronic conditions. We face a special challenge here. We don't want to discourage the investment in research and development in these innovative therapies that are saving and changing lives. Yet the current path, with commercial drug spending rising at nearly 6 times the rate of all other medical expenses combined in the Commonwealth, is unsustainable and can subvert the very success we have made elsewhere in controlling healthcare spending. Together, we must find interventions that are based on getting the right drugs to the right patients at a cost that we can afford. Thank you.
Good morning. My name is Christina Severin. Thank you for having me again today, this year in a different role as President and CEO of a new organization called Community Care Cooperative. We are a new company that is composed of approximately 11 corporate members, all of whom are federally qualified health centers, FQHCs, all the way from Western Mass, from Central Mass, up north, down south, and through Cape Cod. We are organized solely for the purpose of becoming a Mass Health ACO. We very much respect and support and appreciate the work that Secretary Cyrus, Assistant Secretary Sy, and the whole Mass Health team have done in working on the 1115 waiver and the incredibly innovative thinking and work and effort that has gone into the Mass Health restructuring program. We're looking forward to becoming a pilot ACO and to responding to full procurement. I'm excited to be here today to give you our perspective on the roles of federally qualified health centers. I think perhaps referenced earlier in one of the presentations this morning as the have-nots, and the role of the have-nots becoming the haves as we look to tackle the challenge of healthcare cost containment.
Good morning, everyone. I'm Eric Schultz, President and CEO of Harvard Pilgrim Healthcare. It's great to be here again this year. I want to thank the Health Policy Council for the work you do. Very important work, and we are really pleased to be part of this conversation today. Harvard Pilgrim Healthcare, I think as most of you know, is a health insurer across 4 states in New England, Maine, New Hampshire, Massachusetts, and Connecticut, covering about where 90% of New Englanders live now. The beauty of being in 4 states gives us a perspective of just how strong our performances are here in the state. And I want to thank all of you and so many that are here and not here for driving improvement. We do have a long way to go, but we're making progress, and we've got the right information, not all of the information we need, but just the right synergy to keep moving this forward and be transparent and respectfully argumentative with one another to move that agenda forward. We also lead a third-party administrator organization, which is now in 50 states, and it's growing rapidly, frankly, because large employers are responding to the Affordable Care Act and aspects of it that they don't want. And some of those actions will, frankly, have a negative impact on what we're trying to achieve as a nation. And part of the discussions are being held here. Chairman Altman, at last year's session, you asked each of us if we could focus on one thing, what would that be? And I ended my conversation, or my point, on talking about the discrepancy of care for those that cannot afford it or are not in the right places at the right time. And we continue to work hard on that at Harvard Pilgrim. I'd like to begin our conversation with a focus on one, and Matt Vino will throw up or place just a visual. I'm a visual kind of person. But our focus is all about pharmacy costs. And I've brought in, just for an example here, a visual of 2 drugs. We've heard about them, Humira and Enbrel. These are the number 1 and number 3 of the world's top-selling drugs. Give you a size, magnitude, $14 billion for Humira, almost $9 billion for Enbrel in 2015. They treat arthritis, rheumatoid arthritis, among other things. They're biologics. I think what you can see here is a remarkable increase in the charges since 2012 to today. A remarkable alignment of actions of their charges. It kind of makes me feel like the airline industry and what they do with some of their seat prices. What you can see is the charge has gone from $2,300 per patient per month to now almost $5,000. Now that's the charge, the average wholesale price. Insurers negotiate discounts or rebates, and they're somewhere around 40%. So let's take that 40% off. The trend line doesn't change. And it reminds me a lot of being in this business in the 80s and 90s when insurers were negotiating flat discounts off of hospital charges. The hospitals controlled the charge master, not the insurers. And the 25% discount that we negotiated really was almost worthless compared to their decisions to raise the charges. And hence, the industry moved to per diems and DRGs and the like. My point here are a couple. We are very fortunate to have the pharmaceutical industry in the United States. They're bringing drugs that save lives, that change people's lives, and we don't want to change that. We do want to put a spotlight on those gougers, and that's what they are. There are gougers out there that are behaving very poorly and hiding under the veil of a statement that they're saving lives so that they can increase prices as dramatically as these companies have. And if we don't legislate something that demands appropriate transparency for the bad players, I'm not saying everyone, there's some really bad players out there, we need to hold them accountable. If we don't, we're going to see these trends continue. And I believe the slopes are increasing, as you can see on the right-hand side, because they believe there's a short window of time left before such legislation comes forward. So that's my opening statement. Thank you for giving me a few extra minutes.
Well, thank you all, and I appreciate your comments. I think we're off to a good start. So let me turn to my fellow commissioners to see if, I'm sure there are questions. If not, I have a few. I'll hold them for